Launch into session one, and our first speaker is Dr. Ruth Etzioni, who's a member here at the Fred Hutchinson Cancer Research Center in the Division of Public Health Sciences, and Ruth truly is an international leader in understanding screening for cancer, and in particular she'll be talking about screening for prostate cancer. Many of you have probably seen all of the issues related to prostate cancer screening and the recommendations now against screening that is more or less official policy, and it's caused many family practice doctors and internists to not even discuss screening with patients, and Ruth has a very important and interesting understanding of that. So, Ruth?
Thank you, Pete, and good morning, everybody. It's very difficult to talk about screening in 15 minutes, and I'm very cognizant of time because I'm the first speaker, so if I end up being late, everyone else will be. So I very much welcome your questions, both on what the topics that I discuss and any other topics related to screening in the question and answer and later. I also want to just say a word about Norm Breslow. Norm Breslow was, in fact, my first mentor here. I came to the University of Washington as a freshly minted PhD to a postdoc, one-year postdoc in the biostatistics department, and Norm really was a giant and quite intimidating in person, and I was fortunate in that he actually wasn't here that year. So we communicated solely by email, and in fact, I worked on a project that was really a love of his, and that led to tremendous advances, and it was a project in a pediatric kidney tumor called Wilms tumor, and that group that he formed that gathered data and did so much work on that tumor really led to paradigm shifts and advances in treatment of that. So very, very sad to lose him. My title is Prostate Cancer Screening and Treatment in 2016. Of course, this is actually at this point a decades-long story. I'm going to try to focus on where we're at and some ideas about where I think we might be going. And as you know, prostate cancer screening has had its ups and downs, kind of like this graph that shows death rates from prostate cancer beginning in 1975 when national level data from the cancer registry first became released, and the most recently numbers have been released for 2013. So I am talking about 2016, but all the registry data that we have is 3 years behind. So the most recent year is 2013. And what I've shown on the graph are two key points in time: in 1986, when there was FDA approval for the PSA test, and in 2012, when the U.S. Preventive Services Task Force most recent guideline on prostate cancer screening was finally published after several years of debate following the release of their draft guideline. So 2012, U.S. Preventive Services Task Force issued a D recommendation: do not screen for prostate cancer. This recommendation is designed to apply to average risk men, but as I'll mention later, I think it is being applied more broadly and is in fact being misunderstood, particularly with respect to African American men. So why did the U.S. Preventive Services Task Force issue the D recommendation? If it was a couple of years ago, I would have spent the entire talk talking about this because we spent a lot of time as the recommendation was being debated weighing in on our perception of why we felt the evidence had been misinterpreted in producing the guidelines. So the evidence did not come from the population curve that I just showed you, even though that population curve looks very compelling in terms of the timing. We have to remember that the population is the ultimate uncontrolled experiment, and often there's more than one thing going on: changes in treatment, changes in screening, changes in behaviors, etc. And population curves are very difficult to interpret. Rather, the U.S. Preventive Services Task Force based their recommendations on two controlled studies: the two large trials of prostate cancer screening, the PLCO trial in the U.S. and the ERSPC trial in Europe. And I've shown you the mortality results, the cumulative mortality curves from those trials. And you can see that in the US trial, there really was no difference, and even a slightly higher mortality in the screen relative to the control, completely not statistically significant. And in the European trial, there was a difference with the lower mortality in the screen group. And the interpretation of these results was first that, from the task force, was that really the benefit of screening was equivocal, because there was no benefit on one trial and a modest benefit on the other trial. We now know, and even the trial investigators in the US will acknowledge, that the US trial is essentially a failed comparison of screening versus no screening, because there was a lot of screening on both arms of the trial. And the European trial was a modest absolute benefit, but over a limited time. And in fact, we have shown an inflated estimate of overdiagnosis due to screening, but the result of that was a perception that the harms of screening really outweigh the benefits. So this then came together into the reasons for the D recommendation. Now, I'll just say a word about our work. If you imagine an orange, right? And you have an orange, you can see the outside of the orange. We know that inside the orange is a lot of juice, right? So our work is analogous to squeezing the orange, because we have empirical data, we have a lot of data, but the question is, what's the story underneath that? What is really going on with disease progression, and can we try to understand that from what we see? So if you look on the right-hand side of this slide, what I've shown you is prostate cancer incidence in the US population. You can see it's quite dramatic, right? There's a big spike. That's right when screening came in very rapidly into the population in the late 1980s and early 1990s. Now, somebody looking at this incidence curve might say, okay, that's an interesting incidence curve, but when we look at the incidence curve, we see a lot of information there. That incidence curve gives us information about disease natural history, progression in the absence of screening, and overdiagnosis. And so the models that we develop and the methods are designed to extract that information from the data that you observe. And in fact, our analysis, not having a lot of time, I'll just mention our analysis of this curve and our models are what helped us to get a more accurate assessment of overdiagnosis that was half or less of what was projected by the European trial. So, given the D recommendation and looking at the news of the year, there was a lot of news around the time that the 2012 incidence data came out from the registry. And I'll show you that in a moment, questioning whether men were stopping screening, if screening rates were going down in response to all the press that had been going on for a couple of years around the D recommendation. And what this shows is self-reported PSA screening by age and by year. So blue is 2005 from the National Health Interview Survey, yellow is 2010, and gray is 2013. So you can see that there's a drop there from 2010 to 2013, pretty much across all ages. And in fact, if you look at the last few years of incidence, you can see that prostate cancer incidence is really going down faster, and there was a particularly big drop between 2011 and 2012, and the last point here is 2013. So a lot of concern about stopping prostate cancer screening in the population. So one of the things that we did at the time that the draft recommendation came out was we said, what would happen if men stopped screening, and how long would it take, and what would incidence and mortality rates go to? And because we have some understanding of disease progression in the population, we can project out what would happen under different patterns of screening. So the first thing I'm going to show you is incidence of advanced cancer, a diagnosis. And so this wavy line here is advanced cancer, incidence of advanced cancer at diagnosis, and you can see this precipitous drop right around 1990, 1991, and 92, when screening was being adopted rapidly. And we've projected out that the majority of this drop is due to screening. We can't quite replicate it. That might be our modeling. It may be other factors, awareness, imaging. It's unclear, but certainly the majority of that drop is due to screening. So now what would happen if we stop screening? Well, we'd see those metastatic cancer rates beginning to go up if screening is discontinued. And we would see deaths going up, not to the original level of deaths as the way the metastatic cases would go up, because there are indeed other factors at work in that decline. And a lot of our work has been trying to decompose that decline in mortality into reasons, including screening. There certainly have been changes in treatment. There certainly has been an effect of screening. And even with changes in treatment and screening, we're not quite able to capture the drop in mortality. So we project that deaths would definitely go up if we stopped screening, but not to the level that they were originally at. We calculate that over the 13-year period from 2013 to 2025, we would see 36,000 more deaths due to prostate cancer if screening were to cease. So we have always said, we've never agreed that screening should be stopped. We've always said that there must be ways that we can use screening in a better manner to try to preserve the benefits of screening, but maybe to reduce the harms of overdiagnosis and of excessive intervention, which definitely we need to be concerned about. And so when we think about doing that, about screening smarter, preserving the benefit while reducing the harm, we have to understand the nature of screening as an endeavor. And the fact is that screening as an endeavor, and in fact for all cancers, kind of follows this pattern, that among younger individuals, you have to do many tests to find cases of cancer because it's much rarer. And in older individuals, and particularly in prostate cancer, there are many cancers, but many of them would not present clinically if left undetected, and therefore are overdiagnosed and potentially overtreated by screening. I have two test cases here. One is Scott Kelly. He and the astronaut, I was actually on a panel with him once at an AUA meeting, and he and his twin brother both got prostate cancer in their 40s, and of course Warren Buffett, who got prostate cancer at age 81. So what does it mean to screen smarter, taking into account that screening as an endeavor has these properties? The first is to really think about being conservative with screening. And what does that mean? Maybe not to screen the youngest men, perhaps to get a baseline PSA, which I'll talk about in a moment, make it harder to diagnose older men, maybe by having a more conservative threshold for prostate biopsy, and screening less often. We can preserve much of the benefit by not by screening every year, but a little less often. If we can't be conservative with screening, we should be conservative with treatment, by which I mean low-risk men, and people will say we don't know who's low risk and high risk. We have a good idea who is low risk, and low-risk men, and is now becoming accepted that active surveillance is a very, very reasonable option for low-risk men. So how do we know that this is a smart way to screen? Because we did a recent analysis of a lot of different strategies for screening, beginning at different ages, screening for different numbers of years, screening at different intervals, using different thresholds for biopsy. And what I've got here is I've got two complicated-looking graphs that I'll try to explain in a minute. Each graph shows the benefit. Here's the benefit in terms of gain and quality-adjusted life expectancy. So we're not looking only at the increase in life years, but we're adjusting it for quality of life, which can be reduced by side effects of treatment, for example. And over here we have the costs. And the costs basically combine all the screens that we're doing, all the false positives, all the treatments that we're doing. And over here to the left of the dashed line are all the strategies that are negative in terms of quality-adjusted life expectancy. They don't improve it. And what we see is that when we're using, when we treat according to contemporary frequencies and treating low-risk cases, we have a range of costs and we have a minority of strategies that are positive. And the ones that are we want to look at the strategies that are down here because they give us the most gain in quality of life and the lowest cost. And so the strategies that win over here are these ones. They have a high PSA threshold, and they have fewer screening exams, long interscreening intervals. However, if we refer low-risk cases to conservative treatment, to active surveillance, we bring costs down a lot across the board, and we have many more strategies that have positive impact on quality-adjusted life expectancy. So it really can help if we combine conservative treatment with conservative screening and conservative treatment. And so what we're looking to think even beyond this, to even what I'll say, maybe even smarter screening. So I have a question mark here, thinking about tailoring screening to disease risk. And who is high risk? Well, we know that African American men are high risk, men with a family history, more recently, clearly BRCA2 carriers, more generally high genetic risk, and Janet will address this. And it turns out that men with high PSA in their 40s are also at higher risk. And this is a graph that's based on a study of a Swedish data set where men had blood stored in their 40s, and then over the next 25 years, there was no screening in the population, but there's a registry which tracks cases and deaths. And those men in the highest quarter had much higher risk over the next 25 years of having metastatic prostate cancer. So perhaps in men in their 40s, that this can be used as a baseline to even determine whether they need screening and how frequently to screen. So finally, I just want to talk about variation in risk. I've got two slides, one about race and one about BRCA, but in the interest of time, I'll just show you the one about race. Well, this is very pertinent to me because I have people coming up to me at conferences and saying, we're losing funding for educating black men about prostate cancer screening because we're being told that we shouldn't screen. And black men have always had higher risk of prostate cancer diagnosis and death. And our models show that that's because really they get prostate cancer earlier and more frequently. And if we understand that underlying difference in risk, that it really pertains to the frequency of getting prostate cancer, then if men get prostate cancer earlier, and more frequently, and we can estimate how much earlier and how much more frequently, which we have done with our models, we can think about how differently we should screen this higher risk stratum. And so what I'm showing here is the cumulative risk of onset of potentially fatal prostate cancer that would be cause death if not diagnosed and treated. And it's a little bit light, but this is for the average risk population, and this is for African American men. And so you can see that this one reaches the dark curve reaches the same level as the light curve earlier, all right? So the light curve at age 55 for all races is the same risk as in black men at age 45. And the light curve at age 50 is the same as in black men at age 42. So if we have a policy of starting screening at age 50 in the average risk population, then we should be screening black men starting at age 42. And if we have a policy of starting at age 55 in the average risk population at age 45, and we've mapped this out as well for BRCA, if BRCA, like in African American men, has a higher risk of onset, but BRCA men may also have a higher risk of progression, and then we need to think not only about screening earlier, but also about screening more often. So in conclusion, I think, again, if I was talking a few years ago, we'd be talking about does PSA screening work and what do the data show? In our opinion, it's not about whether to screen now, it's about how to screen smarter. And I haven't had time to talk about bringing in new markers for screening that we're also an area that we're working on. The benefits and harms of screening depend on how you screen and also on how you treat. And I want to just end by talking about back to the U.S. Preventive Services Task Force. They are reevaluating their guideline for prostate cancer screening, and I was very gratified that maybe they had heard what we said a few years ago, because a few weeks ago I got a phone call from them. Can we help them with their review of evidence about modeling? So here's holding thumbs. Thank you.
Thanks, Ruth. I know you're going to have a lot of questions about screening. Write them down, and in the QA session we'll be able to ask them. So we're going to move now on into some treatment discussions. So our first speaker is Jing Zhang from the University of Washington, and